We are delighted to have with us today Britany Klenofsky, who many of you remember from her time as a prelim intern with us and then as a neurology resident. And she went uptown to do a headache fellowship, and she's now board certified in headache, an assistant professor of neurology, and leading the Center for Headache and Pain Medicine here. And already authored book chapters and done all kinds of work. And she's been a resource for me about my patients. And she told me she's happy to answer my questions, but mostly she wants me to come to Grand Rounds on the 25th, where I will learn all of the answers. And so I am pleased to be here. I'm sure it's going to be a great session. Dr. Klenofsky.
Hi, everyone. Thank you for the introduction. I'm going to try to be as efficient with my time because I know some of you guys have a meeting afterwards. If there's anything that I didn't cover, feel free to reach out to me. I always like communicating with you guys. I still keep in touch with a lot of people on a friendly level in general. So I was asked to put together a presentation for headache management for the primary care doctor. So this isn't any of like my own personal research. This is more so just a collection of data for you guys of things that as a group, us headache providers have noticed, have tips to give the headache, the primary care doctor for the headache patient, things that we might want you guys to keep in mind before having the patient come to us, and just a collection of new information as well. So I have no financial disclosures. I have no commercial support disclosure, and my objectives. So the objectives, like I had said, it will be for the diagnosis of migraine and some of the more common but maybe less familiar headache conditions, to determine when to image, and also helping us to develop a plan for both the acute management of the migraine patient, but then also knowing when to start prevention. And when discussing both of those things, it comes into play of understanding the risk of medication overuse headache and ways to avoid it for your patients. So as most presentations start, I'll give you patient XX. She's a 26-year-old female who comes to the office with 2 years of headaches. Very typically, my patients are that 20 to 40-year-old female. She says that the headache started during her graduate school classes. The pain feels like someone squeezing my head on both sides, and it lasts for a few hours. So what would we really ask her, and what would we do? Like, would we image this 26-year-old female? So I have here the template that I use for mostly all of my new headache patients. Obviously, I don't expect you guys to be including such an extensive question base, but it kind of just, I wanted to put this here so that you guys can see what I look at for patients. So I always ask them the age of onset when they first started to really get headaches, not just when you start to like notice that they're really a problem. And then I ask them also, what makes you come in today versus maybe 2 years ago when they first started happening. I'll ask them also, where is the pain occurring, how often it's occurring. And then here you could see the reason I ask these other questions is associated symptoms. They are going to tell us whether or not the person has migraine or something else. So they're part of the actual diagnostic criteria. Then you also have autonomic symptoms that I will ask patients. And those are important because while migraine patients might have autonomic signs, like having a left eye that they'll say it's droopy when they have their headache, this is important to identify if they have what's called a trigeminal autonomic cephalgia, so something that's not migraine. And then also neurological symptoms with their headache. You want to ask them things that might trigger or change your treatment plan. So if someone says that they have tinnitus, it might trigger something that maybe we have to image them. If they have hemiparesis or hemiplegia, that gives you a different type of aura that the patient might have and will show you how you have to kind of change your management. So obviously, I'm not going to expect you guys to spend an hour asking them these questions, but what you can do is there's a questionnaire. This is actually adapted from one of the headache books that I use. It's ID Migraine. So it's 3 simple questions that you can ask a patient. They're very practical screeners that will tell you pretty much with a sensitivity of 0.81 and a specificity of 0.75 whether or not the patient has migraine, and could be really useful at shortcutting the diagnosis and getting there. Also, I want to highlight, sometimes patients aren't going to always give you the direct answer that you want. If you'll tell them, are you sensitive to light or sounds? Even saying, do you have a dislike of light? I sometimes find my migraine patients, even though they clearly don't like light, they might not notice it. And it's sometimes easier to ask them, what do you do when you get your migraine? Do you go to a dark and quiet room? Do you go to your bedroom? And that usually tells you more than just asking them exclusively, do you dislike light? Also, some studies have shown that just simply asking patients if they have nausea with their headaches is a great way of just identifying whether or not they have migraine. So we can continue on. Oh, I apologize. This came out formatted a little bit differently. It didn't when I was looking before. But on further questioning, she tells you that the headaches are bitemporal. They're pressure-like in nature. They get really bad in the evening, and she takes 2 Advil and goes to bed to get rid of them. Sometimes, though, she'll wake up with a mild headache, and she drinks a cup of coffee in the morning to get rid of it. She also notes that mom had similar headaches as well. So here are your hidden things in there. She needs to go to bed, so she's likely photophonophobia. They get really bad in the evening, so that tells you that it's more of a gradual in onset and lasts for numerous hours, which gives you 2 things. Tells you that she has migraine by the hours criteria, and then also tells you how soon you need to get medication on board. You have time with her because it's gradual. And just an interesting thing to note, mom has similar headaches, which is not uncommon. Often headaches are familial, migraines are familial. And interestingly enough, also, you might be able to ask the patients, did you have childhood motion sickness? And a lot of times they do answer yes for migraine patients. So here we have the ICHD criteria for headache disorders. And I just point out, you need at least 5 attacks lasting 4 to 72 hours. So that's where she tells you that, she notices it towards the end of the evening that it gets really bad, and she'll wake up the next morning, she still has that headache. That gives you that time frame, versus sometimes people say, I take 2 Advil, it gets better, and they only give you that answer, and they don't acknowledge the extra hours that they're still suffering from minor pain. You need at least 2 of the 4 following characteristics. So she's a perfect example where you can kind of get misled. So unilateral location is something that we often think of with migraines, but that's not required. It's 2 of 4. So she still meets criteria because, she has to go to bed for the pain, and both because of the severity and because it will cause a disruption to different activities, and physical activity aggravates her symptoms. The photophobia she meets as well. Something that I often do have to clarify with my patients, though, that this brings up, headaches, you will avoid activity because activity can aggravate them. It's not necessarily that they provoke them. If a patient tells you that they will cough, or they bear down in the bathroom, or they go to exercise, and that actually gives them a headache when they feel perfectly fine, that's something to clarify with them, because then they do need a different type of workup to figure out if there's a secondary cause of headache. So she tells you her headaches cause her to go to bed. She needs that dark and quiet room, like we said. The sleep, it restricts her normal activities. Duration, more than 4 hours. So just to reiterate this, location is not part of the diagnosis. Do not confuse neck pain for tension type headaches, and don't confuse the bilaterality of her pain for tension type headaches. This is still migraine. 75% of those patients who come in with migraine, according to the Cleveland Clinic, have migraine, have neck pain with it. 40% of migraine patients have bilateral pain. And for the most part, also, just to add in, according to some data, if someone is coming into a primary care office or a non-headache specialty office, the chances are it's 94% likely that they have migraine or probable migraine. I thought that this was just an interesting image that goes into different words that patients will report or use when they are coming in with migraine. The larger fonts are the ones that are more common for them to come in, so that throbbing pressure. But sometimes people will use things like jackhammer, needles. It's depressing. There's a band-like pain with it. So I think I pretty much established with you guys that for the most part, the patient is going to be migraine. I wanted to include here a table. This comes from one of the national headache surveys. It was intended to show somewhat of the disparities in care. But what I wanted to use it for was just to reinforce how important it is to help your migraine patients. You can see from here that there are numerous patients who will come in and numerous people who are affected by migraine. White females report a rate of 20.4% migraine, Black females 16.2%. It's a substantial amount, and it's one of the leading causes of disability. And it's almost an invisible illness, like your fibromyalgia patients and depression. It's very life-altering. It might not be life-limiting, but it's still life-altering and prevents people from doing activities. There's an interesting book, Not Tonight, written by a woman who suffers from migraines, and she goes into details about how there's limited amount of funding. People don't understand, even other neurologists don't understand how important it is to help people with migraines and how it really can interrupt your day-to-day routine and cause you to avoid activities. So just food for thought of maybe wanting to consider getting that book. Okay, so we've established that she likely has migraine, and what do? Do we image her? So that was the next question on here. I included a table that gives you a mnemonic for red flags for secondary headache. For the most part, it's not recommended to image patients, according to both the American Headache Society and the American Academy of Neurology. If someone has a normal neuro exam and a usual stable migraine pattern, there's no evidence to image them. However, that being said, one, you do image when they come in with a different type of headache, like a trigeminal autonomic cephalgia or trigeminal neuralgia. This is done to rule out lesions in the hypothalamus or the pituitary. Trigeminal neuralgia patients, if they come in and they are young, you must also rule out MS, so you do need to image them. Otherwise, you won't image unless there's something that stands out. So systemic symptoms or secondary risk factors. If they come in and there's a concern for possible malignancy, infection, you will image them. If they have, or even LP them, if they have a change in their neuro exam, like there's a focality to their exam, a weakness on one side, a change in their level of alertness with the headaches, you will image. The other thing also is, like I said, most of my headache patients are the 20 to 40-year-old female range. If you have someone that comes in their late 50s, early 60s with headache, it's quite unusual to develop your first headache there. There's actually a second phase around 70s to 80s. That's not uncommon, but specifically around 50s, you're going to start to worry about, why is this person all of a sudden developing a headache? And those people, you will rule out things like giant cell arteritis and malignancy. Here's another table image that I give for reasons why you will image. And really, it's your first, worst, fast onset vascular headaches. When they're presenting with an acute onset headache, within minutes, it goes from being perfectly fine to all of a sudden having that thunderclap headache. You should especially image these patients. It's more reassuring when I have the patient who comes in and says, oh, for years I've had these headaches, and then you can pretty much say that that's primary headaches. More likely than not, when it's someone who's coming in with that vascular headache, you're going to have them in the ER. And in those cases, usually if they're presenting under 24 hours, you can get away with a CT head. But a fast onset headache and they're outside of that first day, even if the CT head is normal, you should get CSF sampling to look for xanthochromia. And just to reiterate, this was published very recently, 2019, in the American Headache Society. We have our own journal, Headache. that there is no necessity unless you have atypical features or red flags. So now we get to the determination of coming up with a treatment plan. How do we come up with this plan? What do we do? What things do we need to consider? So first, I like to determine whether the patient is coming in because they have headaches that they want to treat in the future, or if they're coming in because they have a headache that's still going on right now. And when the headache is going on right now, I ask them, how long has this been going on for? Is this typical of your headaches that they last for 48 to 72 hours? Is this a new headache that never went away? Also, are there associated symptoms with the headache, such as the aura, and asking them what the aura is like to figure out what aura type they have. So, along with migraine, a specification to it is status migrainosus, which very recently I've been getting a lot of patients who have this. So this is a headache that is unremitting for more than 72 hours. They have a typical migraine, but for whatever reason, it's not going away, or they have periods where they get 1 or 2 headaches a month, but you have to specify with them, how long do these headaches last though? And they might say, oh, I get a headache and I'm knocked off my feet for 2 to 3 days. So when that patient's coming in or they send you a message, what I usually have a few options of what I do, and I included them here. There's really no data for how to treat status migrainosus. It's very limited. I feel like there are random case reports and things, but I figured I would just give you the things that I like to do for the patients. So I base my decision on whether or not they've recently reported status migrainosus in the last few months, how I treated them before, comorbidities such as whether or not they have diabetes, and I don't want to give them steroids and worsen their finger sticks. Also, whether or not I can get them to come into the office or go to the ER. In my practice, I actually have an uptown location and we have a nurse practitioner, so that increases availability for appointments. So I can have them come in for nerve blocks and even IV medications. And what I find really helpful is giving people Decadron especially. I know a lot of providers will give other steroids, but I do find that Decadron works best compared to other steroid options. On top of that, also, Medrol dose packs are just pretty expensive. So I find it's cheaper just to give people 4 milligram tablets and tell them to take 3 the first day. And what I might even do on top of that, especially for my patients who come in with neck pain, is I'll also give them tizanidine at bedtime for a week. And usually the combination of the two also makes sure that they get a good night's sleep and the steroids don't ruin that sleep cycle. A great option also, provided that they're not pregnant, is giving people Depakote. When they come into the ER, it's especially important that you have the opportunity to give IV Depakote and you give it quickly. So we can go into that a little bit later, but I put in a point here that I tell them to come in with oral tablets. You give them the IV Depakote and you chase it with the oral tablet, and it often has the best results. And if you notice, I don't have triptans on here. That reason being because once the headache is going on for about 48 hours, I don't find the triptans to be useful at that point. Triptans and NSAIDs are really best when they're used at the beginning of the headache. Once you go beyond that, I feel like you're way behind in the game and you need to address it in a different fashion. By the way, if anyone has any questions, let me know. So the other reason why I ask people whether or not the headache has been going on for an extended period of time, or whether or not it's a headache pattern that is typical of them, that each time they get a headache, it lasts a few days, is because there's also another entity called new daily persistent headache. So this is where a headache starts and it never goes away. It's not a headache that patients will come in, they say they have daily headache, but when they first started getting headaches, they were about twice a week, and then they got worse and worse and became daily eventually. This is when someone clearly, distinctly, they will tell you, on January 5th of 2020, I got a headache and it never went away. They remember this. Technically speaking, it has to be present for more than 3 months to get the diagnosis of new daily persistent headache. That being said, though, when you have the opportunity of diagnosing a patient and treating them for new daily persistent headache earlier rather than later, your opportunity of successfully treating them increases. I think this is especially important right now, given COVID-19. I think a lot of us are seeing that patients are coming in with a daily headache, either after being diagnosed with COVID, or even now we're seeing with the vaccine. I'm a part of different social media groups that are reporting that a lot of patients are coming in. They got one of the vaccines, and then since then, they've had a headache that just won't go away. So I like to just treat them aggressively at the onset. What you have to consider, though, before just treating them symptomatically is that new daily persistent headache might be a sign of something else. Like we said, sometimes you have to rule out things like giant cell arteritis. Another point is that some patients might come in with a daily headache, but it's actually medication overuse headache. And that's usually something that you can note and distinguish if they tell you that, oh, in the beginning, my headache really wasn't actually daily in its onset. It progressed to it. Another important thing is that if you have a patient who comes in with poorly treated or unsuccessfully treated headache and it's daily, you should consider a workup for intracranial hypotension. Some patients will get it after a lumbar puncture, after a procedure, and then there are some people who develop spontaneous tears in the dura and end up with intracranial hypotension. Finally, I just also would like to point out that there is an entity called hemicrania continua. This is an opportunity to discuss something that's not your typical migraine. This is one of the trigeminal autonomic cephalgia types, and it is a daily and continuous headache. However, like it sounds, this one really does have to be unilateral in nature, and oftentimes you have associated autonomic features. Patients might not outright tell you that they have associated autonomic features. You need to ask them things like, do you have some redness or tearing in one eye when you get your headaches or when they're really bad? Or do you have a sense of fullness in the ear? And that will kind of trigger you to think about that. In general, though, I will say that new daily persistent headache is very poorly understood. We think that maybe it comes from developing different viruses, a life trigger, tapering of SSRIs, but we have no clear-cut reasoning for it as of yet. So what we do find to be helpful, this again, a lot of these things are adapted from two of the main headache books that we have available. When someone comes in with the new daily headache, oftentimes we get basic labs, but we will check a thyroid to see, because 14% may be hypothyroid. Another thing is, especially in the Northeast, checking patients for Lyme antibody. I understand that neuro-Lyme, chronic Lyme, it's a very poorly understood and debated topic, but we do find some patients present with Lyme and we can treat them accordingly as if it's Lyme, and then their headaches do improve in some circumstances. A lot of this is based on case reports, so you can see it's very limited, but we do have a few case reports, some retrospective studies that have helped us to determine how we're going to treat these patients. I point this out most specifically because I try to avoid starting patients on prevention when they come in with new daily persistent headache, if they're coming in earlier in the course. There is the possibility that you can treat them and get rid of the headache without committing them to taking a daily medication for months on end. When you start a medication like Topamax or Effexor, you're not going to be able to start them on the full effective dose right away. You're going to have to slowly build them up. So that will take time and they will have side effects. And then when you also find that they do better, it's hard to get them off of these medications. So what I like to trial first are some of the more short-term options. Things like bupivacaine blocks, nerve blocks, which you can do on the forehead, the temples, and the occiput, working together with pain management for trigger point injections as well. Giving people muscle relaxants for a short time can be helpful. And then specifically what I've been trying lately with the new daily persistent headache patients coming in with COVID is I'm trying to start to treat them as if we would with Lyme. Obviously, it's a different virus, and the doxycycline is something that's specifically helpful for Lyme disease. But nonetheless, we don't really know what we're supposed to do right now with COVID and headaches. So I've been trying it, the doxycycline montelukast. Technically speaking, the few case reports that are available, they say to use it for 3 months and to do twice a day singular. I find that's hard to tolerate for patients. I usually do once a day and for 2 months, and then I reassess. This is something that's really new, so I don't have enough data to suggest whether or not it's a great success. But I do have some patients that are, if they are able to tolerate it, they are doing better. And then I don't have to commit them to being on long-term therapy. And this is another table that just shows how you can kind of distinguish how you're going to determine which treatment option you give. So post-infectious, you might consider the steroids or the doxycycline. Again, also for post-stressful life events. But then the point is, with those with a strong component of neck pain or cervical disease, you can consider doing first NSAIDs or muscle relaxants and procedures. Of course, this might require that they come in to meet with me, but I'm happy to see the patients and get them in, and you can kind of start them on their steroids and their nerve block and their muscle relaxants, and then they can come in for the nerve blocks. So also in here is just the IV management for patients who come in with a headache. This is for the residents who are in the ER at times, or if they're admitted to the hospital. One of the first questions you will ask them is whether or not they took a triptan. And this will tell us whether they failed the triptan, whether it's still an option on the table. And then also it tells us whether or not we can give DHE if it's very prolonged headache. How sometimes we do consider DHE IV for these patients. However, in the US, we do not give a triptan and DHE within 24 hours of each other due to the synergistic vasoconstrictive effects. So I think this is a nice little flow table for you guys of introducing steroids, having them get Reglan if they can with a Benadryl, and concurrently doing that with valproic acid. And the important thing, like I was talking about with the valproic acid before, is that you want to give it IV, a high dose. I always go with the high dose when someone's coming in. Don't give partial treatment. And you give it over 20 minutes actually. And it's something that you might have to battle with the pharmacy about, but it really works best when given as fast as possible. And then you follow it up with an oral dose, which also people will think, oh my gosh, that's a ton of valproic acid, but provided they're not pregnant, that's fine. So this is just a table you guys can use as a reference as well. Toradol is also very helpful when it comes to patients with a prolonged headache. I often, when my patients come into the office and they have an active headache, I will give them Toradol IM. Though I do tell patients something to think about is that you cannot give any NSAIDs for the rest of the day, so it limits them. They have to really stick with it, or otherwise it might hurt their stomachs. So we talked about more of the ruling this out, ruling that out. So now we get to our management for the migraine patient who wants to come in with a script to take for what they're going to do in the future. So our main medication options are triptans and NSAIDs. Triptans work by affecting the 1B and D receptors on serotonin receptors and some 1F. Honestly, I think it's very unclear of how they really work. They block the release of CGRP, but not every patient is affected by CGRP. They affect how the vessels enlarge and constrict, but the vascular theory for migraine was debunked years ago. So I think it's more so just the scale of peptides that are being released later on. They are, generally speaking, our go-to treatment options because they work and they've been available for so long. So we know what our side effect profile is. We know what our long-term consequences are. That being said, patients do sometimes feel what's called the triptan effect. The faster onset of the triptan that you give, the more likely they are going to experience it. The triptan effect is a throat, chest, or jaw tightening. It can be very disorienting for patients. It can be very alarming for them. They think that they're having a heart attack. It's nothing vascular happening. It's actually mitochondrial changes to the esophagus. Some patients get it, some patients don't. Just because you get it with one triptan doesn't mean you'll get it with another. So what I do is when I'm starting a triptan for a patient, I ask them, how long does it take for when you start to feel a headache coming on to when the headache becomes its worst? Or do you wake up with your headaches? And if you're waking up with your headaches, do you notice that your headache is starting the night before? So this helps me decide which triptan I'm going to give. If someone tells me they wake up with a headache, but it started the night before, I tell them, you're missing the boat on when you treat it. And then you can give one that isn't as fast acting, and they could take it before bedtime and hopefully it goes away. If they wake up with the headache, that means it's been brewing while they're sleeping, and then you need a very fast acting one. So that's where you get your subcutaneous sumatriptan, or even they have nasal zolmitriptan and nasal sumatriptan available. Ideally speaking, though, I start with my rizatriptan because it's one of the faster acting with the fewest side effects. So I know that a lot of primary neurologists and primary medical care doctors, they start with sumatriptan. I try to avoid that because they're more likely to get a side effect from it, and then they won't want to address a different type of option. And they'll say, nope, that's it. I'm not using that medication anymore, either because of the triptan effect or because of severe fatigue and nausea from it. So I start with middle of the road rizatriptan, and I set expectations with the patient. Tell me whether or not it worked for you. Tell me if you felt too tired from it, and we're going to try something else. We try it as soon as possible, but if you find it made you too tired, let me know, and then we'll try an NSAID afterwards, because you have the best option of it going away is when you treat it early. So there's no point in me giving you a medication that you wait until the end of the workday to take it. I will say though, just as an aside, the rizatriptan and elatriptan, you do have to look at other medications that they're on. If they're on verapamil and propranolol, you actually can't give the full dose. But otherwise, I tell people always give the full dose. Let them get rid of the headache right away, and let them even combine it with the NSAIDs. Those who are sensitive to the triptans, you can give them naproxen, or you can have them combine it. And the sooner you give them everything, the more likely it is that the headache actually goes away successfully. So don't half dose it. I will say also that for cardiac patients, we are not supposed to use triptans, and that's where the naproxen seems to be one of the safest NSAID options. Though in the Headache Journal last month, I believe it was published out of Stanford University, that there really were no cardiac effects from patients using triptans, but medical legally, I don't think you can actually do that yet. So the newer agents, which is probably what you're more interested in, lasmiditan, that was just recently released, and this is a 5-HT1 agonist. So everybody was very happy because this meant that there was a triptan that didn't have cardiovascular implications. I will be honest, I don't think any of us have prescribed it for any single patient. We're kind of disappointed with it. While it is an option for our cardiac patients, it causes significant and excessive fatigue, to the point that patients are actually, we're told that we should actually have them test drive it to see how tired it makes them, and they might even have to register for the DMV. So I wouldn't bother with that. The other options, though, that you can actually try are ubrogepant and rimegepant. A lot of patients are now coming in asking for this because they see the commercials. These are CGRP antagonists. They are the shorter acting versions of them. Technically speaking, patients are told that they can take this in an unlimited amount without affecting their headache pattern. However, they were only studied in a limited dosage range per month, so you are unable to prescribe an unlimited quantity. It blocks CGRP, that calcitonin gene-related peptide, so I do not give it at the same time as the a patient that I have on prevention for CGR with a CGRP inhibitor, because I'm afraid of blocking both at the same time, even if they are a normal, quote unquote, healthy patient. They can be used at the same time as triptans, but because you're generally going to be giving it to someone who's triptan intolerant or they don't work, I tell patients to take it first, and if it doesn't go away, you can try the triptan afterwards. And just as a little heads up, the ODT has a sulfa group in it. The rimegepant is a dissolvable tablet, so that's a good option for those with nausea. However, because of the sulfa group, you might have to watch out for sulfa allergies. I believe that the sulfa group is actually in all oral dissolvable tablet mechanisms, even like the Zofran oral dissolvable, and it's not supposed to be considered problematic in those with sulfa allergies. But again, this is new. I had 2 patients in the last year tell me that they may have had an allergic reaction to it, and we're thinking that maybe it's that. So come up with a plan for your patients. Tell them always to keep the medications available. Alter the plan based on the patient's need. If they are heavily nauseated and can't tolerate the pill, give them the oral dissolvable tablet version, like the rimegepant oral dissolvable or the Maxalt, the rizatriptan or oral dissolvable. If it's really fast acting, give them the injection. But talk them through all of it and communicate with them, because sometimes an option won't work for them, and you don't want them to just think that, okay, it didn't work, that's it. There are so many things that are actually available. You can also combine them with antiemetics. If you notice in the tables before, Zofran and Compazine and Reglan are highly effective for migraine patients. In some studies, the IV versions are actually better than the IV triptans. So I give my patients with nausea the pill version of them, because you have both anti-headache property to it and anti-nausea properties. And I also find it helpful for those who can't take triptans. I try giving them the Reglan to see if that will help with their headaches. An important thing also to tell them is they can use these medications, but do not do this more than 2 separate days a week or 10 separate days a month. It's important to specify this with them, and to also specify with them that it's 2 separate treatment days of any short-acting pain reliever, whether it be a triptan one day and naproxen another day. And the reason for this is because they can develop medication overuse headache. Time and again, we have patients who come in who tell us that they have daily headache, and we listen and we hear that in the beginning, their headaches were about once or twice a week. They hit a stressful period in their life and they started to take their analgesic more often, or they were given 50 milligrams of the sumatriptan instead of 100 milligrams. So the headache was partially treated. They went from having an 8 out of 10 to a 4 out of 10. So they thought, okay, I'm better. And then they go to sleep, and the next morning they still have that headache. And then they're treating it again the next day and maybe the day afterwards. And then their brain kind of retrains itself to expect the short-acting analgesic. This can happen with as few as 9 days a month of NSAID or triptan treatment. So I actually limit the amount of pills that I give the patients. Oftentimes the insurance company limits the triptans anyway, but even if I give them naproxen, I give them about 20 pills each month, and that gives them enough that they could repeat the dose, but can only treat so much more. I'm going to go a little bit faster just to make sure I finish. But if you notice, I did not include Excedrin, opioids, or butalbital. That is because these are really, really bad players in medication overuse headache. Excedrin not only has the analgesic, but also has caffeine, which caffeine can be a double-edged sword. In a short acting time, it can get rid of the headache, but in long term, it can actually promote more headaches. As few as 6 days per month can give you a medication overuse headache for Excedrin. 5 doses per month can be done with butalbital. The tricky thing with butalbital is that while the headache, the analgesic effect will last 3 to 6 hours, it actually stays in your system for 35 to 88 hours for just 1 dose. So it really lingers there, really, really easily contributes to medication overuse headache, because you can basically just end up with a continuous dose of the butalbital in your system. That being said, don't just take that away if they were prescribed it by one person, you can certainly send them to me, but still refill it, because if you suddenly stop it, you can have life-threatening withdrawal symptoms, seizures, delirium tremens. So for those patients, I come up with a 1 pill a day withdrawal, or I actually do a phenobarbital taper in some patients to do it safely. There's really no reason to ever give opioids for headache patients, unless maybe there's the rare occasion of a pregnant patient, which technically in some circumstances it could be better. But there really are so many options available. Even with the pregnant patients, you can figure something out. Send them to me if they become more complicated in that regard even. So when you send them away, you also need to keep in mind that whether or not you want to start prevention, and you need to keep in mind whether or not things are working. So I tell patients to keep a diary, whatever is easier. Some patients will download applications that help with keeping a diary, but they can be really cumbersome. So I tell people, keep a sheet at your bedside. I'd rather you just write a check mark for a day you got a headache, or do a 1, 2, 3, and 4. Even if it's a mild headache, I want to know, because that will contribute to all of the total headache days that you're going to be treating. If someone says that a lot of times patients come in and they just tell you, oh, I have 4 headache days a month, 4 migraines a month. And they don't tell you that like 10 other days, they still have this background noise pain, or they still have a milder pain that they just build up a tolerance to it. Also, have them include the as needed medications, because sometimes patients will say, oh, I take it when I get a headache, and you're kind of just going in circles with them. And it helps you to figure out whether or not they have medication overuse headache. I also tell people to draw out any visual symptoms that they get, and to take note of other symptoms that they get when they're getting a headache. And this is helpful to tell you whether or not they have migraine with typical aura, whether or not their findings are simply an ophthalmologic issue that they need to be treated. Migraine with aura, a typical aura will be fully reversible visual, sensory, and/or speech language symptoms. This should last from 5 to 60 minutes. If they tell you that they have a 1 or 2 second flash of lights, that's not the aura. Have them go to the ophthalmologist. They can still take triptans. There's some people that think they can't use triptans if they have aura. That is fine, as long as it's a typical aura. Patients will also be concerned because the aura they feel lasts for a very long time. Each aura symptom can last for 5 to 60 minutes. So you can start with your visual symptom that lasts for 20 minutes, then your sensory symptom, another 20. The point is that they should always be unilateral. A reason to know for this is also because it tells you when to start prevention in terms of magnesium. What we found is those with typical aura have low pockets of magnesium in the occipital area of the brain, and that's where the aura is coming from. So if you can supplement with magnesium, that will help. Another thing that's important of identifying our migraine with aura patients is that it does increase the risk of stroke. It's an otherwise uncommon entity in women under the age of 45, but those with aura, the rate can go up. So you can have like 5 to 10 per 100,000 women years. That then increases 6-fold if they're using an oral contraceptive. So that's the most important thing. We don't know if each aura affects stroke risk factors, but we do know that having them on an OCP is dangerous. In terms of the aura, if they tell you that they have symptoms like having double vision or fully reversible motor weakness, then they actually have what's called a brainstem aura or hemiplegic aura, and then you won't give them a triptan. So it's important to go through all of the symptoms with them. A lot of times patients come in and they tell me, oh, I have migraine with aura, oh, I have this syndrome. I tell them, let's not identify it with the term, let's describe it. So I tell people also, bring me a picture. And this is just something that can illustrate some of the auras that people will have. And you can ask them, how does it grow, which will also help you. Tell them, close one eye at a time. Do you notice in both eyes or one eye? Is it your visual field or is it the eye? I actually just got my first aura and it was about half of this in my vision. And I was developing, I thought, oh, wow, the screen is bothering me. And then I thought, oh, I'm an idiot. I'm a headache doctor. I'm having an aura. So like I said, these are reasons to discuss when you're going to start prevention, how often they have the headache, how severe their symptoms are, and their risk of medication overuse headache. A patient typically for me, I will start prevention if they tell me that they have 6 or more headache days a month. That being said, I am more likely to start prevention sooner rather than later if they tell me that they have hemiplegic aura and I can't give them a triptan. And also because if they're at work and they can't move one side of their body, even if that's just 2 days a month, that's very significant and life altering to them. So usually it's for the chronic migraine diagnosis patient. I put in here the table. Your chronic migraine patient is someone with 15 or more days per month. And on more than 8 days per month, they meet the criteria for migraine. That's really the main point that you need to meet for Botox. But otherwise, I personally will treat when they're being affected more often than not, and depending on the severity. If it changes their life, I discuss it with them. I also think that this points out that you don't really need to make the distinction for tension type headache, because your headaches in here for chronic migraine, they can still be tension type for a lot of them and still be considered in your overall table for chronic migraine. And we also don't really have treatment options specifically just for tension type headaches. So in my opinion, it doesn't really matter. But here, you can see that tension type headache, if it's a shorter acting or really long lasting headache, that is more likely to be the tension. Again, the table says bilateral, but you can have unilateral, but more so it's ones that really don't necessarily inhibit activity. So what do we use for prevention? I think a lot of you have seen that patients with migraine come back from us on Topamax, metoprolol, propranolol, or amitriptyline. Interestingly enough, the amitriptyline is actually level B evidence, but it's better than giving someone valproate. I see Dr. Klenofsky has a question. I don't know how to open it though. Maybe we'll just ask it at the end. So the valproate, generally speaking, even though I give it in the acute setting, I won't give it for someone to be on long-term management because of all of the side effects. But what I wanted to point out is kind of the fact that we can tailor some of the prevention means for other things that they're affected by. If someone has a sleep problem, I give them amitriptyline because sleep problems will contribute to migraines in and of themselves. If they complain of a lot of dizziness with their headaches, I give them Topamax. But what I wanted to make the most important thing was that if we could work together as a team, when you have a patient who comes in with headache and hypertension, propranolol and candesartan and metoprolol are really helpful for migraine. So if you have someone with both conditions, maybe instead of starting amlodipine or nifedipine, you might go to candesartan first. I find candesartan, even though it's technically still considered level C, societies are trying to increase its level of evidence. And I feel like it has fewer side effects a lot of the time. Propranolol, you have to worry about your asthmatics, also some depression that can be worsened by propranolol. Also, with some men, some impotence might be inhibitory for their use. With candesartan, other than allergies or allergic reactions or lightheadedness, I find they often tolerate it fairly well. So the other things are once they're refractory and they continue to have these headaches, either they continue to suffer despite being on them for more than 3 months, or they have a side effect, they can't tolerate it, then we can apply for the insurance for Botox or the CGRPs. So we have 4 currently available. They either affect the receptor or the ligand. They were marketed as being great for migraines. They were going to be super responders in patients, but we haven't really had that phenomenal success that we thought. That being said, there are some people that are super responders. They must have elevated CGRP in their system when they get the migraine, but we're not just there yet to figure out who it is to know. Also, I've always been concerned about this and its effect on vasodilation, and whether or not if someone were, to be that cardiac patient, we thought that we would give it to these patients, but maybe not if it's going to get in the way of their compensatory mechanism if they were to have an MI while on it. That's certainly why I don't give the GPANT and the CGRP at the same time. And very recently, actually, Arinamab added to their label in April of 2020 that it can cause not only constipation, but also hypertension. So it's something that I've been on the lookout, and I really use Botox first, just because it's also been available for so long. So also, I wanted to include non-medication options for patients. I don't always want them to think that I'm just giving them a pill. There are petacytes or Butterbur. This used to have level A evidence. Do not give it to your patients anymore. It needs to be purified to avoid liver toxicity. It's a reason why you need to talk to your patients about supplements also that they use. The place that made it without that liver toxic ingredient closed. So I tell people magnesium and riboflavin. It used to also be our go-to when it came to pregnant patients, but recent OB studies show it might affect fetal bone development. So it leads me to telling them about hydration, exercise, sleep patterns, TMJ, and devices. So there's the Cephally device. It is expensive, but it's a one-time fee with a 60-day money-back guarantee. You wear it on your forehead, it vibrates on your head. Some patients love it, some hate it. For 20 minutes a day, a pregnant, breastfeeding, elderly patient can use it to prevent each headache, and then you can wear it for an hour to get rid of each headache. And 20 minutes each day to prevent, and an hour to get rid. I feel like the fact that they give a 6-day money-back guarantee also really speaks volumes to how good it is. The other thing is right now during COVID, it's over the counter just recently, and they give a coupon right now. Then there's the Nerivio device. This is a new device, very mixed feelings about this. You wear it on the arm, it connects to your cell phone, you raise up the intensity of the vibration, and you have to use it within the first hour of getting the headache. Otherwise, the device is not helpful. Basically, the way it works is it tells the brain that something painful is going on. Let's release a lot of serotonins to be happy and overcome that pain and not feel the pain. It is $100, so it's a little bit cheaper than Cephally. It requires a prescription, but you need to get a new one for every 12 treatments. That being said, it's sometimes just as expensive for a trip down for patients. It's about $12 per treatment. Okay, I included things about COVID-19 and the CGRPs, but I'll leave that since a lot of you guys have to leave. But hopefully from this, you gain the understanding of that most patients that come to your office with headache are suffering from migraine. Really speak to them about all components of it so you can tailor their treatment, and give them something that really works for them so they could treat it right away, get rid of it as soon as possible, and avoid a lingering headache and avoid medication overuse. I have numerous references if you would like, and then here, any questions?
Excellent. We have like 2 minutes, so maybe Beth, did you have a question?
I didn't. I clicked on the wrong button.
Oh.
Thank you, Britany. Great talk.
Can you come up with a question? Thank you, Dr. Klenofsky. We'll take one question if somebody has one out there. Nothing. Nobody.
I can ask a question if nobody else has a question. It's Dahlia. Great talk, Britany.
Thank you.
I'm so proud of you and your training here. I have to
Thank
say,
you.
I'm very what about, I mean, I joined a little late, so maybe you covered it, about everybody using computer screens now and blue light glasses and everybody that seems to have a headache. And I am interested in the COVID stuff, so maybe you could share your slides.
So I didn't actually include anything on the blue lights. There are actually glasses for very light sensitive patients, not even looking at the screen, but there's something called Theraspecs. They're this like ruby red lens. Some patients are getting them. Some people do find it to be helpful. In terms of the blue lights, you know, I feel like just being someone who sits in front of the screen and hearing patients, there must be something to that blue light affecting it. I think it certainly affects sleep patterns. And I tell my patients who are bad sleepers and get headaches, I tell them, get rid of the phone, get rid of the screen at the end of the night. Your melatonin is not working because of that. Whether to get the blue light glasses, I mean, Amazon has them available so cheap. I feel like it's worth a shot to try. But I recently even asked one of my ophthalmology friends, and she said there's no clear data about them. A lot of it's just anecdotal. That being said, in terms of COVID. What I saw, I just tried to pull up as many resources as I could. I think a lot of you guys know I've been getting so many referrals for patients who have new daily persistent headache, either from having COVID, having the change in their schedule from working from home and not having that outdoor time where they commute, not having a good setup at the desk, not having a good sleep schedule anymore because they're going from bed to couch to bed. 6 to 71% of patients, it seems, are presenting with new daily persistent headache. Maybe it's a cytokine storm from the headaches and from COVID and the inflammatory markers. There was one study that suggested it might be related to hypoxemia. That being said, the vascular theory for headache was debunked recently, so I don't really feel like that counts as a reason. I've been trying to treat these patients as if they're just a regular new daily persistent headache and somewhat like my post-Lyme patients. Depending on whether or not they're going back to work, I've been very aggressive with some patients. I've been starting one thing at a time with other patients. What I've been doing is often having them come in for nerve blocks 3 times separated out by 2 weeks. In the beginning, we weren't giving people steroids because we were afraid of whether it would worsen COVID, but I have been starting that. I've been giving them tizanidine, a muscle relaxant, because I feel like a lot of them also have neck pain. The last month or so, I've been giving them the doxycycline and Singulair, and it's too soon to tell whether or not it's helping. For those, there's a handful of the patients that said, I can't tolerate the doxycycline even with a probiotic for a long time. But as a group, we've been debating, do we image and LP these people? At first, I was imaging them because COVID has been causing people to be hypercoagulable. But with a normal exam, most, if not all of the patients have had nothing come up other than a white matter change. And then we've been debating whether or not to give them candesartan or CGRP antagonists. So on the one hand, we've been a little bit hesitant towards the CGRP antagonists because of its secondary vascular effects and the fact that COVID can make people hypercoagulable. But something was just published very recently that showed that the CGRP antagonist might actually be helpful for severe COVID patients because it also blocks some of the cytokines that cause acute lung injury in COVID patients. And I saw that Biohaven is actually in the works for their own Gepant. I think it was called Vizegepant. Don't quote me on this. A nasal spray that would have high affinity for the CGRP and used for not even headache patients with COVID, but just patients with severe cases. So we have been kind of loosening our restrictions up and giving it to some of the people. Once, of course, we've had to fail other things too, though, because the insurance companies won't give it for COVID. It has to be given for a chronic migraine patient.
All right, I'm going to actually cut you off.
Okay.
I'm sorry, it's 12:59.
That's okay.
Thank you so much. Maybe if you want to share with us your office information so we can make sure we refer you the right patients and ask
Okay.
all those questions, that would be
I don't
great.
have it on the slide, but I see patients at 5 East 98th Street and 10 Union Square. Send me an email. I'm very easily available that way.
All right, very good. Thanks,
Thank
everybody.
you.
And thank you, Dr. Klenofsky.
Have a good day, everyone.